Might have to click OK again.
Starting drinking early today, Allison.
Just hydrate.
We are live. Yep.
Okay, great. Wait for our group to join in. I can go ahead and start with our introductions. Welcome everyone today to our third session in our summer health policy series, where we are, our topic today is city policy, forming unique partnerships to improve health. Then I will start with introductions of our esteemed panelists. First, we have Catherine Patterson, who is co-executive director of CityHealth. Thank you for joining us today. We also have with us Captain Kimberly Elenberg, who is the modeling and analytics lead for the Department of Defense COVID Task Force, and particularly relevant for our panel today. She has had a distinguished career in a number of public health roles, including her work with the Office of the Assistant Secretary of Defense for Health Affairs, Office of the Chief Medical Officer as the Deputy Director of Population Health and Medical Management, and then her role also in medical readiness in the Office of Force Readiness and Deployment. And thank you, Captain Elenberg, for joining us today. And we also have with us Dr. Bill Hazel, who is the Senior Deputy Executive Director at the Claude Moore Foundation, and previously was here at George Mason University and also the Commonwealth of Virginia Secretary of Health and Human Resources. Welcome, panel. I am delighted to have you here today. What we'll do is start, please, with Catherine Patterson. Can you give us your perspective, please, on local partnerships and how CityHealth approaches their work?
Yeah, I'm excited to be here today. Thank you for inviting me. I'm going to pull up some slides just to share with you all. So I'd love to talk to you all a little bit about the work that CityHealth does in the realm of policy and partnerships. I will say this at the outset, we literally cannot do our work without local partners and our national partners on the advocacy front. So who are we? CityHealth is an initiative of the Beaumont Foundation and Kaiser Permanente. And we have curated a package of 9 policies that are based in evidence that show returns for improved health outcomes. And we do that by taking a social determinants of health frame, which really is looking at everything from where we live, where we play, where we work, where we pray. So what do we actually do? We have 2 major work streams. One is an accountability arm, and I'll talk a little bit about that in a minute. And one is an action arm, which really lends itself to our conversation today about partnership. So every year, we assess the nation's top 40 cities on these specific policies that we have endorsed. And then we award cities medals, a gold, silver, bronze, or no medal in each one of these categories. What I think is most exciting about the work that I get to do in partnership with my team is we actually provide direct technical assistance to cities that are interested in moving up their medal rankings. And I'm going to share a story and just a little bit about what that actually looks like on the ground. So some of you all may be interested in terms of how we actually choose our policies. We have 3 guiding principles, and I'm actually going to add a 4th. Those are pragmatism, achievability, and an aspirational nature. I will also add that we've just gone through a whole strategic planning process, and we are also adding a focus on health equity in our work as well. So probably most importantly for CityHealth, all of the policies that we endorse are based in evidence that show a return for health. In addition, those policies must be under city jurisdiction, and we have to have seen a precedent. While promising policies are great, we really want to look at examples of what works and how to be able to scale that up across the country. Then our last step in the process is actually to run this by our policy advisory committee. That is a group that is comprised of subject matter experts, leaders in the field, and we've actually had local leaders, local mayors sit on that group as well, which makes sure that we're not only adhering to our guiding principles, but we're actually choosing something that is of the real world and that is relevant. So what are the 9 policies that we work on? We work specifically on affordable housing for us. That's a policy called inclusionary zoning. We work on safer alcohol sales, which look at the density of alcohol outlets and those practices that they utilize. There's actually an incredible correlation between the density of alcohol outlets and violent crime. We work on a policy called Complete Streets. This ensures that everyone within a community has safe places to bike, to walk, to ride in a car, to ride on public transit, to get around their city safely and efficiently. We work on earned sick leave. I don't think any other policy on this package has been more relevant during the COVID-19 pandemic, and we continue to see a need for having access to earned sick. We work on restaurant grading. This is knowing that the food that you consume from outside entities is safe and will not get you sick. We work on healthy food procurement, which looks at the food available on municipal properties, making sure that you have healthy options when you visit a city property. We also work on high quality pre-K. The returns for pre-K for children who have access to really high quality programs are astounding, and we keep learning more. We hear things like increased earnings over a lifetime, better health outcomes, lower rates of teen pregnancy, and on and on and on. And then we also have 2 tobacco control policies. One is smoke-free indoor air, and the other is tobacco 21, which ranges the purchasing age of tobacco from 18 to 21. So how do we award these overall medals? I do just want to note that we don't require any city adopt all 9 of these policies in order to get a medal. You can see right here, a city must receive 5 or more gold medals across each of the 9 policies in order to receive an overall gold. This was very intentional. We fully understand that cities have different priorities. Residents are asking for specific action in specific areas. And so therefore we tried to give cities a lot of on-roads to an overall gold, which I think has really helped with the applicability of the package writ large. Okay, so I'm going to tell you a story. I'm keeping my contact information up here in case you want to reach out with any additional questions. But what does this work look like on the ground? What is that action part that I talked about earlier? And I want to share a story about San Antonio, Texas. So in 2017, when CityHealth put out its inaugural assessment, San Antonio earned no medal, and they were not happy. And we got a phone call from their then health commissioner, Dr. Colleen Bridger. And she said, look, San Antonio is a great place to live. We believe we're doing all the right things to support health in our community. What do we need to do to be a gold medal city? And so we came back to Dr. Bridger and said, here's where you fall on this assessment. You have the option of moving these 6 policies. Let us know what resonates and come back to us and we'll figure out a way for us to support your work. So Dr. Bridger went to the mayor, Mayor Ron Nirenberg, who's still the mayor of San Antonio. And she said, here are our options. What do you want to prioritize? And he looked down the list and he said, tobacco 21. I believe strongly in protecting the children of San Antonio. Let's do this. And Dr. Bridger took a deep breath and said, are you sure you want to do this? And he said, yeah, what's the problem? Well, for a little context setting, at that point, no other city in the state of Texas had passed a tobacco 21 ordinance. So this was going to be a game changer, which Dr. Bridger knew. And she looked at the mayor and said, great, let's roll up our sleeves and let's do it. So in the span of 6 months, the local advocates within San Antonio worked together. They built a grassroots coalition. That coalition was comprised of everybody from members of the military, because that's such a big presence in San Antonio. It was comprised of youth groups, of members of the local health system that were really passionate about that. the Chamber of Commerce played a huge role in this. And through our partnership, CityHealth was able to bring to bear our partners, such as the Campaign for Tobacco-Free Youth, such as the American Lung Association, such as the American Heart Association. And CityHealth also asked, is there anything else you need in terms of helping you guys work on this issue? And they said, we have a great coalition. We've got obviously local leadership. We have a local champion. We would really appreciate some support for a local paid ad campaign. We said, no problem. We provided a modest amount of support, and they were off and running. This was a sprint from start to finish. They started in, I would say, September of 2017. By January of 2018, the City Council successfully adopted Tobacco 21 as an ordinance in the city of San Antonio, making them the first city in the state of Texas to have a T21 law in the books. Interestingly enough, the state picked up this issue when the legislature reconvened and actually passed the law at the state level. And then what I think is a really great story, a year after that, the federal government passed this law at the federal level, really providing a lot of blanket protection for kids, especially as we think about some of what we've seen with some of the illnesses around vaping a couple of summers ago, which was really interesting. I also just want to report that much to Dr. Bridger's excitement and the mayor's pride, San Antonio actually earned a gold medal in 2019. They are extremely proud of it, as they should be. But I think this shows the really profound partnership that can be built between a national initiative, such as the one that I have the opportunity to work with, and that political will at the ground level, really looking at ways to improve the lives of community residents. And what happens when we're able to bring all those supports together, we get some really fabulous health promoting policies on the books. So with that, I'm going to turn it back over to Allison and stop sharing my screen. And I'm excited to talk a little bit later with questions.
Wonderful. Thank you so much. And I'd like to turn now to Captain Elenberg. I know your work have thought a lot about population health and workforce readiness in your context. Can you tell us about the partnerships that you've been able to form and successful partnerships you've observed working with the Department of Defense?
Absolutely. And I think the partners would almost be too numerous to name. However, I want to back us up for just a second. And if everybody has a dollar bill, and they can take out their dollar bill, flip it over so George is not facing you, and instead what you see is the eagle. And if you look at the eagle and you look in the eagle's talons, the eagle is holding olive branches in one set of talons and is holding arrows in another. That the head of the eagle is facing the olive branches. And that is truly symbolic of what we as a country all desire, right? We prefer peace over any engagement. And the role of the Department of Defense is really to deter war and, if need be, fight and defend the nation, right? But in order to deter war, we need to have a strong, resilient, and ready military force. Now, we know it can't all be active duty. It's too expensive for the country. So a third of this force is made up of reserve component members, meaning they wear the uniform proudly, but they are members, first and foremost, of a given community, and then they are called upon when needed for their reserve component activities. And so it's really important to understand the makeup of our force. Not everybody in the Department of Defense consistently has access to health resources. It could be a physical distance to an installation. There's a lot of reasons people don't live near an installation. It could be a state that has zero installation because they're only reserve component members. It could be access because just like full-time employees versus part-time employees, the access to resources vary depending on your status. But we always need strong mind, body, and spirits, and that occurs locally. Where we live, where we learn, where we play, that's what really shapes us. So the Department of Defense had looked internally to say, what are our business practices, our policies, what are our doctrines, et cetera, and programs that help shape a healthy lifestyle, a healthy community, which ones don't, what can we do about that? but we knew we needed to look externally as well, because most service members don't live on an installation 24/7. In fact, 70% of our population lives out in the communities in general, and almost 100% of that reserve component National Guard force does. So since the majority of our people don't live on an installation, that necessarily means that we need to understand this is a shared responsibility. So the Department of Defense is made up of all volunteer members, right? Nobody's right now drafted into the military. We still have an existing draft, but at the moment it's really all volunteer force. And so it's actually a great opportunity. I myself grew up at the Milton Hershey School and was the recipient of the generosity both of Mr. Hershey and an ROTC scholarship, and it allows me to sit in the seat I'm in now. I would have never had this opportunity for an education had it not been for this ROTC scholarship. So I was very, very lucky. We want to make sure that those who are interested in volunteering are able to volunteer, especially since we're depending on this all-volunteer force. Well, for a lot of us, it's the first time we have access to healthcare. A lot of us, it's the first time we have access to secondary education resources, et cetera. We also, when we do invest in folks, we want to make sure that they're healthy and well and that we can retain them. It's a lot of money. It's about $1 million we invest in each submariner as we, cultivate them and send them underway. It is a lot of, this is a lot of our national security. And when they return, because we always take off the uniform at the end of the day, and we're part of the communities we live in, and we are assets to those communities. We are football coaches, soccer coaches. We are volunteers in the classroom. All in every way that we can contribute to communities, we do. So we are federal assets, we are state assets, we are local assets, and I think COVID really highlighted this kind of shared responsibility where, over 11 million doses of vaccines were delivered in a fairly short time period because we worked together to set up large distribution centers and try and roll things out. And I'm not saying that anything went perfectly. There's lots to learn there, but we certainly did worked hard together to make sure we could do what we could to mitigate the impact of the pandemic. So if this is a shared responsibility, who do we partner with? How do we know where to even begin? This is difficult. There are so many non-governmental organizations, so many states, and within each state there's a plethora of counties, and then there's federal sister agencies, and it becomes really, really hard to know how to begin to build these bridges and these relationships. And so, we worked to identify the means and the mechanism for doing that. And so one of the places we started was we said, well, what's a measure of if we have to have a group of folks who are strong in mind, body, and spirit, and that happens locally, how do we know that we're achieving that or not achieving that? And so we looked at some measures and metrics that we could get to publicly. And so we came upon the health-related quality of life as a validated measure. We mapped it back to the electronic health record and found it was an indicator of readiness and ability to complete a deployment and integrate well back at home. And so we almost created a health-related quality of life score for communities. And we said, could we create bivariate maps so we knew where our people were by county, their actual, where they're actually living, not necessarily installations they're assigned to, and could we look at the health-related quality of life score for that community based off of a holistic framework, right? We call it total force fitness. And where we identified dense populations of our people that and then could see risk or they were doing well, we had the opportunity to learn. Where things were going really well, we could go into those communities, meet with folks in those communities and figure out what was contributing to really good scores. And where there was high risk, we could go in and see what was not contributing well. One of the non-governmental organizations we partnered really strongly with was the National Association of Chronic Disease Directors. We also got some good guidance from the Robert Wood Johnson Foundation, and like I said, just way too many to name. But the National Association of Chronic Disease Directors helped us really understand that 2 belly button points within each state that would be key and important would be like the governor's initiatives, if the governors had some initiatives, and then the state public health improvement planning boards, and at the local level, the county health improvement planning boards, and that also went to the economic improvement planning boards because there's such a close tie between economics and health and well-being. And so instead of looking at things regionally, and instead of looking at things by service, we looked at things holistically as a Department of Defense community by state, because we also found that states have individual laws, policies, and regulations that can either preclude or increase access to resources. So by looking at things at that state and county level, by partnering with non-governmental organizations, we were able to say, identify those areas of risk using a federal sister agency health-related quality of life score, and at least triage where to begin the bridges and the partnerships. So if we worked with the governor's offices, if we worked with the state health improvement planning boards, and then we worked with our key federal agencies, we had a good start. And then we could look at the individual health-related quality of life score for those areas where we have service members living and see what additional partners that we really needed to focus in on. And where we implemented this process, we found increased readiness, increased retention, and hopefully we will see increased recruitment to all volunteer military. And again, it is volunteer. So if not, this is okay as well. We're interested in healthy and well communities overall because that makes a stronger country. And so we're very grateful. Some of the federal sister agencies that we've partnered with, of course, include the CDC as a key partner, and they have SAMHSA and among others. So, many of them fall under HHS. But the FDA, USDA has been a huge partner, particularly around food nutrition and food security and insecurity. So I just, again, the Rolodex that I have is so fat, filled with rich context. And the bottom line is we as a Department of Defense couldn't do this without them. So to sum some of this up, I really just want to make sure that folks really understand that the Department of Defense is leaning forward, really looking at things from that preventative public health perspective. The Defense Health Agency is establishing itself with a strong foothold in community health. We really look forward to partnering with you with our other resources like Military One Source and the Defense State Liaison Office that can work with states on local laws, policies, and regulations. And just cannot express the gratitude for the opportunity to participate on this panel. And I turn it back to you.
Thank you so much, Captain Elenberg. And they've raised a whole bunch of exciting questions already. I want to turn it to Dr. Hazel. From your perspective as a senior official in a private foundation, did you want the slides or did you want informal remarks? Let me just check in here.
No,
Yep,
I will share slides.
Perfect. Excellent. Wonderful. I see them
Yeah.
coming up.
I
Fantastic.
can make that happen.
We'll turn it over to you in your role as a senior official in a foundation. What is your take on collective action?
Well, thank you, Allison, and I would like to speak to you a little bit from the perspective, not just from the foundation here, but also from my 8 years as Secretary of Health and Human Resources in Virginia, where going from practice of orthopedic surgery, where you take care of people one at a time, to dealing with populations, it became really interesting. And the first thing I would comment is that this is all about linking silos. Someone once said that if you break down silos, grain spills everywhere and you have a mess. So it's really about linking them. And we think of silos as being vertical. This was out the backyard of the house where I grew up. Both of these, the verticals, and you can't forget that they're horizontal silos. And in this game of working in CityHealth, which is the topic, you have to remember this is a three-dimensional chess game. You have federal, you have state, and you have local, and you managed to get all three of us covered today. So I actually wanted to talk a little bit about how we went about looking at collective impact, and then think a little bit beyond that is to show you an example that worked. But the idea is to go from that mishmash of everyone going in different directions to alignment around shared goals, shared strategy, and an action plan. And what the model that we used was a collective impact model. I can refer you to the Stanford Social Review 2010 article that really is I think the original piece related to this. But collective impact is a way of bringing people from different organizations with different goals, purposes, et cetera, and figuring out how you work together on a specific topic. And it starts with the things like setting a common agenda. Can you agree on the goals? How would you know if you're successful? Can you agree on the way you're measuring and reporting success? Are we agreeing to do mutually reinforcing activities? We don't do the same things in different organizations. We don't do the same things the same way. But can we think about how we all fit into the paradigm? Then this requires continuous communication. You hear it in baseball and football and sports. Everybody on the team has to communicate constantly. And to do that, you need to have some sort of a structure. And that means the creation of a backbone support organization. And in fact, that's what we're doing at the Claude Moore Foundation related to some health and human resource issues in Loudoun County. We're also doing it related to a statewide health workforce development program. Now, it's interesting, Dr. Elenberg used the term well-being. I was happy to see, but I'm going to give you an example of how we looked at this in Virginia. And it took a term to figure out, one term for me to figure out where we were, and then another term to actually think about doing it. So this is a long-term project that really began 2013, 2014. But I asked the Commissioner of Health to think about well-being in Virginia. And this was sort of our framework for well-being that we created, that we were operating from. And this talk isn't about the framework. This talk is about actually the implementation. We also had another issue in Virginia where historically you would have families ping-ponging between agencies. You had different programs. In fact, we had a graduate student do a fiscal mapping for funds for kids age 0 to 21. And in 2017, at the end, we identified for kids 0 to 21, not including K-12 classroom, not including any spending going to colleges, that we had a budget of $6.18 billion in 2018 that flowed through 151 different programs, 17 agencies, and 4 secretariats. So our thinking was, how do you actually begin to focus these on a child? Children don't live in agencies or in programs; they live in families, or and families are different. So how do you begin to think about it a little bit differently and look at all of the social determinant factors? So we thought about the parameters of a healthy, connected community. Again, not really the point for today, but we set up under the governor's direction the Children's Cabinet in Virginia. And this is a diagram of what it was. But if you'll notice here, you had, I co-chaired it with the Secretary of Education. We had Public Safety, Homeland Security represented, Commerce and Trade. The First Lady was involved primarily because she was a great advocate for nutrition and eliminating hunger. She used to say that it's hard to be hungry to learn if you are just plain hungry. And then Dr. Northam, who is now Governor Northam, was part of it. And we had a number of programs, including one called the Challenged Schools Initiative. We had 3 districts in Virginia that were really struggling. One of them was in Petersburg. And what we were trying to do, they had no accredited schools, 7 schools for Petersburg. None were accredited, had not been, and there were ongoing challenges. And so we decided that we wanted to work in that area. And we had a graduate student who found us in the education leadership program at Harvard. She was getting her PhD. Her name was Daniela Louie, brilliant woman. And I'm using her slides. I want to be sure she gets credit. for this. You'll find that those of us who were secretaries really didn't do much except take the credit for other people's work when the governor didn't take it, but we also took the blame too. So it's that's what we did. But anyway, we looked at the city of Petersburg, and I think this generalizes pretty well. Everybody has a day job. And when you're working with groups and you're coming in and trying to create some sort of a collective impact, you realize that you're asking people to pile on to something when they're already busy. Then you're addressing the issues of culture. You know, we used to joke in orthopedics, the orthopedic reason number one is we never do it that way. And orthopedic reason number two is we always do it this way. And so this whole issue of the culture that you're coming into is going to be really important as you need to lead and change. Then there's the perception. I think that many folks start, particularly if you're coming to help them, theoretically, you've identified a problem. And then that means, well, we've got a problem. We are in a deficit-based world and we aren't finding the opportunities. And that is a part of the culture, I suppose, but it stands out on its own. And in our case of the city of Petersburg, it was missing from its own table. What you would not know about Petersburg from the history is that Petersburg had the largest population of freed African Americans at the time of the Civil War. What you may not know about Petersburg is that African Americans also owned slaves. And as a result of that, 100 some years later, there were divisions in the population that needed to be worked through and thought about. So Daniela created a theory of action. Can she create the trusting relationships? Can she shift mindsets from deficit to asset base? Can we think about how we're bringing the state power and resources? Can we create the dialogues and organize the interagency planning? What we had found is that the local conversion foundation had more or less given up because they couldn't get their act together, wouldn't get their act together, didn't get their act together. And so we decided that we would try to help in this situation. So Daniela was marvelous. This is Secretary Holton, who is the Secretary of Education, now at George Mason. Her husband is Senator Kane, but she helped build the relationships. We started thinking about the mindset here. It's the woe is me, we don't have the resources and so forth. We don't have the ability. Thinking about how you empower this mishmash of organizations and individuals, all that had their say, and then bring them together for a dialogue. And the thing I think that's really interesting, and we saw this with our activities around homelessness and opioids, behavioral health, that there's a basic, this does work, this idea of working together. And what we were able to do in short term is put social workers in the schools. We set up home visiting for teen moms. We organized our data sharing. The Algebra Project, which was a national program, returned to Petersburg after leaving earlier. We became a summer feeding sponsor. I want to tell you about the Magic Pass program. As we said in a meeting in October of 2015, we were talking about absenteeism of teachers. And somebody said, oh, yes, and it's about to go into the worst time of year. And I said, what do you mean by that? She said, well, as we go into the holidays, these kids don't have school anymore. They don't get fed. They go home. They don't have activities. So in advance, they start acting out. So in that room, the conversation grew, well, we're going to get the YMCA to offer opportunities to churches to do some feeding, and we're going to give them free bus passes. And they did. And at the end of that vacation, they realized we can do this in the summer. That program continues to this day. We set up a housing pilot program, thinking about if we can keep kids in school, we know the data shows that if the child changes school during the school year, that value of that year is lost. Can we pilot or prioritize keeping the kids and the families in a house so they can stay in school till the end of the year? I don't have data on that yet, but that program continues. A school health clinic was started, and there have been several other things. So we feel like this idea, this how you do it really worked for us or worked for this situation. So I'm happy to take questions, Allison, when the time
Sure.
comes.
Absolutely.
Needless to say, you get me wound up, I could go on for a long time, but I won't.
No problem. Thank you for those marvelous examples. And I love the way we've hit this topic from different perspectives and different levels. I wonder, Kathy, if I could ask you, since tell us a little bit about how you see what City Health does as different from a Culture of Health Prize, the County Health Rankings. These are lots of different ways of coming at a similar theme. What do you see as some of the options there?
That's a great question. And I just want to acknowledge my colleagues, but great presentations. And I agree with Bill. I love we're coming at the local, the state, and the federal level. I love the county health rankings. And for those of you who are familiar with them, they are a great demographic snapshot of where each of the counties are in America. It's an incredible data exercise. The folks who run that are incredibly smart. What I find frustrating about the rankings is that there's always a number one and there's always somebody at the very bottom. And it is almost impossible to move up in those rankings because, as we all know, a lot of health is tied to things like income. A lot of things are tied to the environment, as Captain Elenberg noted, all of the things that, where we live, work, play, and pray that influences our health outcome. And the Culture of Health Prize is a great example of where Robert Wood Johnson is taking the initiative to recognize communities that are making real strides in improving the overall health and environment within communities across America. It's wonderful. What I really wish we would do, and Bill, maybe this gets to busting the deficit thinking model, is every single community has opportunities to improve community health. And that is something that City Health has focused on. Where are the positives here? What can we look at that can help change the conditions in which people live that can then lead to ultimately better health, more resilient communities? And I think that's what kind of sets City Health apart. We absolutely have an accountability component. We are trying to be very public and transparent with our data, what laws are on the books, where can cities improve, how can we help highlight that? But we also have made a commitment to working in partnership with cities who have an interest in working on some of these policies and want to pass some of these policies to help improve community health and population health within their cities. So I think those are the major differences that I see.
Excellent. And then Captain Elenberg, we've heard a couple of components that sound like that are important for making these city partnerships work and move forward. So one was identifying where to develop a partnership. And you mentioned your health-related quality of life metric, and essentially what sounded to me like mapping it and overlaying it where you have density in your own population, and then partnering with the National Association of Chronic Disease Directors, or in other instances we heard American Heart Association, American Lung Association, or even the Algebra program, right? And so what other key ingredients do you see? How important is it to have the local champion, the local leader? What would you do if the community wanted to enter in where you needed to identify that person and the table was empty?
Those are excellent questions. Yeah, so I feel really bad because I failed to recognize all of our partners and key partners, and there are just so many. One of the things that we noticed was that our state health coordinators, our belly buttons in each of the states, felt overwhelmed. They were taking a lot of meetings with a lot of really good people that were focused on a lot of great areas, but they weren't actually able to get tackle a problem and see a measurable like dose intervention, right? So that we didn't know, they were just so stretched, so thin, meeting everyone. And so, they came to me and they said, well, how do we determine, who we build bridges with first? Not that we want to exclude anybody, but how do we manage our time better to build the relationships we need to address whatever it is we're tackling within a community? And what I suggested to them is that we back up, that we look at, what are the things that are impacting the health, well-being, readiness, and resilience of the service members that we need to ensure are strong and able to deploy and return well. And are any of those priorities shared with the local leaderships where they live? And if they are, then, could that then lead us to the local champion? Could that lead us to where there is political will to make a difference? Does that lead us to something where there's already synergy and energy and we can build upon the positives? So similar to to CityHealth, it's important not just to look at what's going wrong, but to also look at what's going right, or where the passion lies, where we're going to actually make a difference. So an example of that would be in a given community, perhaps there was, we have a lot of disease, non-battle injury related to musculoskeletal or poor nutrition that's preventable. So maybe we want people to get a little bit, better or healthier access to a healthier diet. Maybe we want them to have a little bit more physical activity. When you look at the state health improvement plans or the community health improvement plans, a lot of times what you'll see in there is maybe the community itself is facing challenges with diabetes or heart health or something else. And so they are also prioritizing perhaps nutrition and physical activity. And so even though there are reasons for targeting nutrition and physical activity may be a little bit unique from ours, right? Ours is from a readiness perspective. Theirs is from a more chronic disease perspective, preventing chronic disease. The outcome or the goal is the same. And so where a governor might be putting their priority, or that state health department or the county health department might be putting that priority, and might already have a coalition of people excited to do that, could we build off of that, join in on that where it aligned, and then we focus on building those bridges and relationships first, and as they get strong and stable, we can expand out to some of the other unique areas that we would be trying to address. So we tried to get to the art of the doable. Perhaps in a given county or state, we were seeing 5 or 6 things that were contributing to poor health. Well, if we had to down select to focus on 3 things, figuring out which of those 3 things would have the biggest impact on the population was one thing, but truly finding where that local champion is, where there is a will, that was key to, I think, our success. So, that way it's easier to build relationships when you all have a common goal. I hope that answers your question.
Absolutely. It sounds like there's a combination of identifying the communities, the common goal, and having perhaps on the menu a set of strategies that one can agree on. So in the CityHealth example, you have your 9 points. There, the community guide has suggestions for effective community-based interventions. And I imagine that your work might be guided by similar menu of evidence-based.
Absolutely.
And then
absolutely.
Bill, I had a question. Really, I'd like to start with you, but it's really a question for all of you. We're in a moment right now where there's a fair bit of infrastructure funding, and some of the priorities you all articulated also include an infrastructure component. So what would be some policies that we could change to make it easier for local communities, whether it's cities or counties, to be able to respond? Now, some of the funding that came out recently really had to be used for an immediate crisis situation, frankly. But these forward-looking funds or infrastructures is sort of for the middle and long-term investments. How can we help cities and counties think about how to prioritize, how to go after them? What kinds of things might help, and what kinds of things might stand in the way currently? I think you're on mute, Bill.
Y'all might be happier that way, but there's been a flood of funding that's come in over the last year or so from related to COVID, and it's mostly through the and this was designed strictly to be remedial or to remediate the current problem. The most recent Recovery Plan Act that is the 1.9, or I forget how much the federal is, but Virginia, it's $3.8 billion coming in over the next 3 years. And the challenge with that is right now over 250 funding streams have been identified. Some money goes to the state, some money goes to local governments, some money goes directly to school systems. The rules for some money is designated for nonprofits, which is why we're interested in that at Claude more. I think the important things are it is to think about how you can encourage your community to have a conversation about the best use of the money. The challenge we have with short-term funds and boosts like this is the chronic problem that we have with CDC funding. Everything is year-to-year grant-driven that has to be competed, and when the interest moves to someplace else, you're left with an orphan program that doesn't have funding. So we have to think in terms of, all right, as a community, have the conversation, wait, this is one-time money. This is your chance to build something, infrastructure that has to be sustained. And I think the having those conversations is really important. In most counties, I know Fairfax is one, you've got the school board is separate from the county. And what happens at the end of the day, they run out of money and then they come to the philanthropic world to say, hey, Kathy, can you give us some money so we can do these things? And I think we have to be the voice up front saying, hey, there's this funding stream. Let's think about how we can do something collectively that's sustainable, that can help. And that's what we're actually working on right now in Loudoun. And there's a group called the Virginia Funders Network. It's been established. It has just under 100 funders in it that gives between $200 and $300 million a year away in Virginia. And we're trying to figure out where the money streams are coming, where the money, who can get it, and then how do we best compete for it? So those are the conversations that we're having. So a long answer to say, I don't know yet.
Thank you. And Captain Elenberg, what is your take? Is there something that in your role as forming these collaborations with local communities that you see can help them access in the most effective way these infrastructure funds and have them go to shared priorities?
So it's interesting. I think a shared priority that I think really rose to the top is the ability to exchange data and information. And, whether it's DoD playing the role of public health response, whether it's assuming the shared responsibility for a healthy, U.S. population, so that we can have this all volunteer military, we really have to think about a coordinated process for requesting data from each other and being able to exchange data with each other. Certainly, we had a lot of states and counties want to understand levels of immunization. And if we can't share that information easily, if we can't request and share that information easily, how do we, the DoD, know which of our members are receiving their vaccinations within a community? How would a community know which of the DoD members are actually getting vaccinated within the DoD? And it really ties our hands in our level of fidelity and understanding of the health of the community if we can't share and exchange data. And so I would say that there needs to be a workflow for this capability, and I would say that's the one that rose to the top, at least for me, as far as being a barrier.
Excellent. Thank you so much.
Allison, can I jump in and respond? Dr. Cuellar is aware that we have one of the projects we've been working on is related to opioids, and like most of these problems, they don't really respect geopolitical boundaries.
All right.
And the issues come from locality to locality discussion, and then from locality to state, state to federal in the mishmash of rules. And the issue is not the technology. The issue is the working out the data sharing agreements. And I think the issue here is to not just say, oh, we're going to share all this data, because a lot of people don't like that. As you know, we see the backlashing, but to really target what is essential and find the ways to have a
Correct.
rule and regulation based to do that. And in fact, Dr. Claire is working on a project like that in Fairfax right now related to sharing of opioid information between human services, health, and criminal justice.
Right, right. And that's very much of a partnership across the county agencies, indeed. And Kathy, what is your take on the work? Does the type of work that you do, organizations like yours, help cities prepare when money drops suddenly, as Bill was describing, and you need to move quickly, and yet you want to work together and you want to approach it thoughtfully?
A great question. I loved Bill and Captain Elenberg's answers. What I would also add is we work in deep partnership with the National League of Cities and the U.S. Conference of Mayors. And these are folks that are well steeped in what's happening, when the money's coming. There are a couple of areas that I would highlight that are ripe for investment. And one of those is green infrastructure. And what I mean by that is, what is the natural environment that exists within cities, such as parks, schoolyards, corporate areas that also have natural elements to them. These are critical components of a healthy community, especially as we think about climate adaptation and mitigation. And I think it's only going to become more important, obviously, as time marches on and we see the impacts of climate change. And so one of the things that we are doing specifically is looking at how many parks are there within cities specifically? What does the investment look like from year to year within cities across America? And then also, we're also looking at tree canopy. Who has access to tree coverage? We know that trees not only provide shade, but can provide a significant heat reduction effort, particularly in areas that suffer from heat island effects, which has deep ties to redlining and other areas that have been disinvested over time. And so we are absolutely working with our partners like the Trust for Public Lands to help increase awareness around this and how critically important this is, not only from an immediate standpoint, but also for planning for the future and helping communities thrive long into the future. Excellent.
Thank you. And I wondered also, since if we come at this from a health policy standpoint, some of the things that you mentioned for this are city health priorities, and this may occur also in the work of the DoD. You may face state preemption issues. Can you talk about sort of how you strategize around state preemption when there's something that a city would like to do that the state has not yet opened its policy window for?
Yeah, this is a great question. So there are excellent cases of, I would say, preemption that helps the public health. One great example of this is Tobacco 21. California passed Tobacco 21 very early on, and all cities and all residents got to benefit from it. But there are other negative health impacts of preemption. So for example, when I'm thinking about the state of Tennessee, localities cannot pass tobacco control laws by themselves. They need to be approved at the state level. And Nashville has been having a ton of conversations about smoke-free ordinances, particularly in light of the fact that their designation as a music city, how can they keep both performers and attendees of events safe? So I think the way that we approach this is thinking cities need all the tools in the toolbox. And when you remove some of those tools, it hinders the ability of cities to respond to the needs of their residents. So we really look at this from an angle of what is within a city's ability to do? How can we help support them? How can we help maybe think about change at the state level? But ultimately, if cities cannot be responsive to the needs and the specific requirements of their constituencies, that hinders the overall health and wellness of a community specifically.
Thank you so much. And we had Captain Elenberg pointed out a couple belly button entities, and one being state public health improvement planning boards. And then she also mentioned the economic planning boards. And Bill, you're creating a funder network. Do you see your entities like funder networks working with the planning boards of different types in the local areas?
Yeah, I think a couple things. First of all, many of the philanthropies cannot be involved in, quote, advocacy, or has to be very careful about what is considered to be advocacy and what is education as universities and state entities and so forth. But I think that what philanthropy does, when we first started thinking about convening philanthropy, what we noticed, I noticed the secretary, is that the funds that are coming in through the government are enormous compared to what philanthropy can do in most cases. And it's like dropping big rocks in a pile, right? I mean, this just comes in, and if you ever see a rock pile, there are lots of cracks and there's dirt that accumulates, and then creepy crawly things start to come out of them and all. And
quite an image.
These rocks only communicate by their weight and their gravity. So the question comes is, and if you stack rocks, it's not really a stable structure necessarily without mortar. So can philanthropy be the mortar that, or the interface that creates the communication and helps with the coordination and pays for the things that these programs don't pay for? I mean, every congressman that ever lived as a Congress has a named program, right? And there's a constituency around that named program that doesn't want that program to change because they've been feeding off of it. So the question then is, that's how I think we fit in.
Terrific. And Captain Elenberg, do you see your role as the DoD as a similar sort of mortar kind of role, or do you see it somewhat differently?
Well, can I say both?
Absolutely. You can be a rock and you can be mortar. Absolutely. Yes.
Thank you.
DoD's a little bigger than most philanthropy.
I was going to say, that was almost a rhetorical question. Yes, right.
Yeah, and I see our role evolving, right? As we come to have a bigger public health framework and presence within the Department of Defense, and that evolves, and we realize the power of influence. It's funny, I read, you always say, I wish I knew then what I know now. When we look at our obesity challenge, that all of us on this call, right, all of our respective folks on this call and our professional backgrounds are trying to address optimizing, health and well-being. The Department of Defense can unintentionally help speed up great public health efforts and initiatives. And the Department of Defense can inadvertently sometimes impede it, not intentionally. And the good example of that is what I was alluding to is, for example, we needed rations during World War II, right? That could and during the World Wars, that could survive on the shelf for extended periods of time. And so we developed, in partnership with the food industry, technologies that would allow extension of food products for those deploying troops. But a lot of those extensions of food products meant more processed food, and it meant that we moved away from eating clean foods and fruits and vegetables and things like that to things that were more shelf stable. There were economic reasons for making that change. There were time management reasons. For the DoD, the reasons initially were to feed the troops. But the consequence then of having technology for more processed food, and then us changing our diets to that more processed food for that plethora of reasons I just kind of threw out there, probably really helped contribute to where we're at today with the obesity epidemic. And so, and that was never the intent when we were looking at extending the life of food so that deploying troops could have something in their bellies, but so we just have to be careful, as an entity, to always think about those secondary and tertiary consequences, positive or potentially negative, that could come down the road. And sometimes we are going to be blind to that. And that's where having partnerships, bringing this back around to partnerships, comes in really handy, so that if we make a decision for one thing and then there are unintended consequences that have a ripple effect on other things, positive or negative, we need that 360 perspective and that feedback loop so we understand what it is that we do and what it is that we influence and how we influence things, and we can just be thoughtful about it. We would never go back and change the fact that we needed shelf-stable food. We did. But if we had understood down the road what that could have possibly contributed to, the challenges it could contribute to with obesity, maybe collectively, we and our other partners, had we anticipated that, could have thought about educating folks earlier about what are healthier options, or things like that.
Yes.
We just don't know.
Thank you so much. Well, we are at 2:00, and I want to thank our panelists so very much for participating today and for this excellent discussion. And obviously for your very hard work in this area and improving our health and health policies. Thank you and have a wonderful afternoon.
Thank you, Allison.
Thank you.
Catherine, Kim.
Thank you.
Bye-bye.
Thank
Thank
you.
you,
Bye.
guys. Bye-bye.